Go right ahead, Chris, whenever you're ready.
Excellent. So positively thrilled to share with everyone about one specific suicide intervention that can be done that's pretty brief, pretty tangible, which is nice because time is often limited. And so it's nice to have something you can do with someone right away to reduce their risk of death by suicide or attempting suicide. So this is sort of a follow-up to a talk I gave a little while ago to this group, which was more of an overview of suicide prevention and suicide assessment. So we'll kind of pick up where we left off in some ways, but just by way of a tiny bit of background. So in the past, when I've talked about suicide assessment, you want to know a variety of things about folks who you identify as at risk of suicidal behavior. And so it leads to some sort of decision-making that's something like this, where basically you're going to figure out, does this person either have a history of multiple attempts, some kind of resolved plans, or elevated specific suicidal desire or intent, plus something else that puts them in a situation where you've got to do something. And so there's lots of different ways that these assessments take shape, and we discussed a few different tools. One that a lot of people use is some version of the Columbia scale. So this is a very pared down version that was designed for a variety of kind of first responders and folks out there in the community. But it kind of highlights the point that when you do suicide risk assessment, you're going to end up with some kind of stratification, some kind of levels of risk that's going to guide what you do to help someone. And so certainly there are folks, and this is their decision making from this scale, who are in that kind of yellow category where, yeah, there's maybe some kind of passive suicidal ideation or some history, but there's no current risk. And so for that person, it's sort of, you give them referral information for the future. If they need to call the crisis lifeline, if they need to connect or reconnect with services, you empower them to do that. And so where we're kind of turning our focus today is to folks who are in kind of that orange category, that moderate to high risk category, folks where you've done your assessment based on some risk you've identified, and you have to now do something to address the risk. So this isn't necessarily folks who are at that highest level of acuity where you have to take them to a safe place right away, but people certainly who have given you enough indicators of risk and enough concern that now you have to do some kind of affirmative procedure to help them. So reminding ourselves about sort of the recommended standard care for people who are experiencing suicidality. Again, in order to help someone who's suicidal, you have to first figure out who they are and know who they are. So there's this identification and screening piece that we've talked about. You'll need some kind of way to assess them and to organize people into these sort of low, moderate, and high risk categories. Where we'll focus today is that safety planning piece. We look at these recommended elements of standard care. So this is having an organized procedure to help folks stay safe and mitigate their risk. And then something that'll be happening in most of the settings where you're at is this kind of ongoing outpatient treatment relationship. But for other settings or in situations where this is new or being reestablished, the other big component is to make sure folks are connected with some kind of ongoing outpatient care. All right, so the broad overview of safety planning is really a few different key pieces. So you want to help orient people to the things that let them know they're at risk of suicidal behavior, so those triggers and vulnerabilities. And then what you're doing is sort of laying out the stuff people can do to reduce their risk. And you're doing it in this sort of organized, sequential way that might be a little different than what people have tried before. So what is often a kind of default advice you give to someone, or that folks, the message people get when they're having a suicidal crisis? What do you think they typically think to do?
Anyone?
So if someone is suicidal, what do you think their kind of idea in their mind is of what they have to do if they find themselves in a suicidal crisis?
Relieve the pain.
Yeah, relieve the pain in some way. And for a lot of folks, what would be sort of the action they would take to address a suicidal crisis?
Make a plan.
Yeah, make some kind of plan. And if you were to kind of think in terms of what a lot of our treatment settings recommend to folks, where do a lot of folks with suicidal thoughts get steered towards?
The emergency room?
There you go.
The emergency room?
Yeah, the emergency
Oh.
room. So if you were to just pick up the phone and start calling various mental health treatment agencies around America, you would get a message that would be pretty similar, especially if you call after hours, which would be something like, here's our phone tree or our business hours. If this is an emergency, call 911, route towards some kind of emergency room sort of situation. And I think that's the default for a lot of different settings that work with suicidal folks, or places where suicidal folks might turn. And so this is a little bit different, where you're trying to sort of expand that range of options to include some other sorts of types of coping and interventions that are certainly on the way to the emergency room, because that can totally be an appropriate intervention in some cases. But there's a whole sequence of things that you can lay out for folks to help match the level of their suicidal crisis with certain levels of intervention. And not only is this all kinds of improvements for efficiency and helping the system work better, but I think it really is better for patients, because you're kind of empowering people that there are things within themselves, within their current level of resources that they can do to mitigate and reduce that risk. And so that's what safety planning is all about, is just giving folks a way to think about that. Some really recent evidence, just to kind of show you what's been done, is Barbara Stanley and Greg Brown did this big study with folks at VA emergency departments and found that if you did safety planning with them, and the next study they also added on a follow-up phone call, which you can imagine all the ways that you would tend to have follow-up with people in a variety of ways during outpatient work. But when you did safety planning plus this follow-up call, they saw that the sort of future risk of having some kind of suicidal behavior decreased in a meaningful way. And then also the odds that someone would engage in some kind of behavioral health treatment increased in a way that was meaningful. And so it was some nice kind of clear evidence that this sort of routine that a lot of us intuitively feel is helpful is shown to be helpful when it's evaluated systematically. And so there's some real real implications to this work in terms of actual outcomes when this has been studied formally. So safety planning has been around for a while. There's a lot of different versions of a safety plan to reduce suicide risk. Lots of proprietary psychotherapies include some kind of safety plan. They'll call it different things, like a stabilization plan, right, or various different names. But they all sort of boil down to these same key elements. So the one that's on the screen right now that I'll share a PDF with folks, this is from Barbara Stanley and Greg Brown. This is their kind of safety plan intervention form that they use. It's freely available on the internet, so anyone can use this for free, which is a big bonus. And it's also got just the basic things that you would need to have an effective safety plan. So we'll share this with you, but really anything that has these elements is what you need. There's no exact worksheet you need. There's no magic in the worksheet. It's having this sequence of things that you offer to folks who are struggling with suicidality. So going through the different pieces, the first thing you're going to do is want to figure out with someone what the warning signs of suicidal thoughts and kind of urges to engage in suicidal behavior are. Are people really good at knowing what their warning signs are?
Yes.
Sometimes. I heard a yes and some sometimes. What kind of things do people tend to come up with when you try and figure out what the warning signs are for them that help them know they might be suicidal?
Feeling trapped?
Hopeless?
Yeah, feeling stuck or trapped, absolutely. Anything else?
Not heard?
Not heard?
Hopeless.
Hopelessness, absolutely. So these are very, similar to the things a lot of us have heard when we've worked with patients who are suicidal. And I think what's, kind of something to think about with safety planning is taking something like feeling trapped or stuck or hopeless, clear, empirically supported reasons people kill themselves and are at risk of this behavior, and trying to think of how you kind of distill those very big feelings and big experiences into something that's very discreet that someone could notice. So one way to do this might be to think with your patient about, when you feel trapped, you absolutely are at this increased risk. We could look at what's happened before. And then you might ask a series of questions around how do you know you're trapped? When do you notice you're trapped? How would you know that you're feeling trapped in a way that increases the chance you might try and hurt or kill yourself? And then pull that into a level of detail where it really is, I notice that when I get a call from my mom, and that's actually not the most supportive relationship. It stresses me out. Or I notice when I get that email from a debt collector, that really kind of causes me to start to have these thoughts. It might be when people go by a certain physical place. It might be when people have a feeling in their body that makes them uncomfortable, right? There can be all these sort of interoceptive internal cues that lead to things like suicidal thoughts or urges. And so it really is trying to get specific in a way where someone could notice these things that tend to sneak up on people. And so there's a range of different levels at which this emerges. For some people, it's very meaningful that for them, the warning sign is if they're going to the medicine cabinet and getting the pills they're going to use to hurt themselves, that's a warning sign. We would tend to want to work a little bit ahead of that, but for some people, that's sort of where they land, and that can be okay. Ideally, it would be at a level of concern or a level of suicidal thoughts, behavior where the emotional intensity is going to be low enough for someone to do some other coping. So for a lot of people, once they're enacting a behavior or engaging in preparatory behavior, oftentimes that situation can be intense enough that it would be hard to do other coping. So trying to work back from some of the obvious tangible behaviors can be very useful. And then also thinking about that depending on where someone is, those warning signs could be very different. So the warning signs when you're sitting in your apartment alone could be very different than the warning signs when you're in a public place. And so just kind of trying to consider all the different axes of how to know what occasions suicidal thoughts and behavior for folks. And so one technique that might be helpful is if anyone's ever heard of chain analysis, which is a big part of DBT and some related approaches, is if someone has the sense that, you know, I just get suicidal sometimes and I just start cutting my wrist or I just start doing this thing, is to really get molecular about what led up to suicidal behavior. And I'm always really surprised that when we really break it down, it'll be stuff like we work backwards from, you know, where they found the pills in the top drawer in their bedroom. We start working backwards and they put down the phone after a conversation with their sister and had the thought, I'll show her, she's going to be sorry. And now you've actually got something to work with, right? It's not, I just take pills. It's, I had this really intense conversation and then I had a thought. And now you start to get the pieces that could fit into this part of the form, the things that could help you prevent a crisis from really developing. So you're going to get some sense of how people know when they're in trouble, when they need to start thinking about other coping. Internal coping strategies. Those are stuff people can do themselves to kind of either distract or help with those intense feelings and those difficult thoughts that can lead to suicidal behavior. What kinds of things do you think people might be tempted to put on here? Stuff they're going to do to feel better? I'm sorry, I couldn't quite hear.
Self-harm behavior.
So this could be, yeah, it could be that self-harm behavior is part of their coping, right? So the non-suicidal self-injury crowd. One thing that I notice comes up quite a bit is when I do this with folks is I'm going to lose a bunch of weight, go back to college, fix these really horrible relationships that have fallen apart for many years, and help the American government run smoothly, right? They just are, right? All the biggest things in the world they're going to do. Is that what you're going for here?
No.
Some head shakes there. Yeah, that's not going to work, right? Because they've got to leave your appointment that day, or they've got to, you know, leave the hospital. They've got to go back to their life after this session. And we've got to have things that exist currently. So what kinds of things do you think might end up here on these internal strategies?
Go to the movies, go for a run.
Nice.
Something like that.
Call a friend.
Listen to music.
Call a friend, listen to music. These are exactly the kind of things that you'd be thinking of. Netflix is a big one for a lot of folks if you have access to Netflix or access to a smartphone. This could also be all the things if if you're like me and you see Marsha Linehan's list of pleasurable activities in your mind, it's taking a hot shower, it's doing any kind of relaxation or meditation work you like to do, it's eating your favorite food or at least food that makes you feel kind of good. All that stuff you can do to either be distracted or feel some kind of feel better even a little bit is what goes on here. And it's got to be stuff that people have access to right away. So lately I've been in my outpatient work seeing quite a few folks who are at least a little bit homeless and have pretty limited access to resources. And that I think forces both the patient and you as a clinician to be pretty creative here because it might not be possible for them to do all their favorite things. So it's really focusing on stuff like, well, you can take a hot shower at the shelter, at least most nights. And you know, there's one aspect of the food you have available to you that you really like. You can go to the public library during business hours. So you can see how I'm thinking. It really is trying to find what's better than nothing, what's better even if it's not perfect, what's available at different times of the day. So depending on who your person is and what their access to resources is, this can, you know, vary, but making sure it's things that are immediately available and that are kind of naturally or inherently reinforcing. So then what you do, so that's kind of within yourself, stuff that you have access to on your own anytime. Step 3 is getting them to identify folks that they could contact. And again, it's to provide distraction or basically to provide genuine caring concern, social support, small talk, contact that is positive and socially supportive, but is not specific to suicidality. It could be, that's not something you have to exclude, but it's trying to help people think of who they can talk to that they don't necessarily have to talk to about their suicidal crisis, who's not necessarily going to walk down a clinical decision-making pathway with them. This is just solid, positive social support, caring concern is who you're looking for here. So friends and family, it could even be a neighbor depending on your person's situation, someone they can talk to about even something very simple, even something very ordinary, just to have some social contact. For the places here that are on this list, this is sort of goes with a lot of evidence that for the most part, the vast majority of people who hurt themselves on purpose do this not in public. They do it in some kind of private setting. They do it out of the view of others. Of course, we can all think of some really poignant exceptions to this, right? When people jump off of buildings and bridges. But for the most part, that's not a public activity. And so if you can work with someone to find places that they feel safe in, that are kind of positive places where they can be around people and be distracted, that can be extremely helpful. And most of the time, that's incompatible with suicidal behavior. It's pretty rare for someone to start cutting on themselves in a public place. It happens, right? But it's pretty rare. And most people will see that as a sufficient barrier to help them stay safe. So this is a little bit different, where for that last step, it was just all about social support, talking to someone. This is really about asking for help and could be specific to suicidality, but basically acknowledging I'm in or near crisis and I need some support, I need some help kind of staying safe, getting out of this, thinking through some difficult thoughts. So again, could be friends and family here, but it's got to be people who are trusted to a pretty high level. For a lot of the patients that we work with, would you say they have lots and lots of people that they could name for this kind of a thing? Lots and lots of trusted people in their life? Yeah, maybe not. And that often is part of the psychopathology that folks are experiencing, right? So if you're working with folks on the psychotic spectrum, part of the psychopathology is difficulty with social interactions, bizarre experiences or negative symptoms that really get in the way of having kind of solid connection with folks where you feel comfortable sharing this. And so there are some ways to overcome this, I think, in terms of considering the whole range of supports that are out there. So not just family and friends, but if there's any kind of important communities, so this could be like religious or spiritual support often fits in here, where that person's going to feel some kind of obligation by virtue of their role that might overcome some of the inherent difficulties of having or establishing relationships that folks experience. But also this could be where you have different kinds of case managers or paraprofessional folks who aren't necessarily trained in suicide-specific interventions, but could help orient someone to help steer someone towards effective resources. Nice to have a range of time frames for folks here, because if it's just the person who's going to be around 9 to 5, that can be pretty limited because a lot of crises happen late at night. One resource that I just remind myself about and everyone I talk to about is the warm line is in a lot of places. It's not everywhere, but in a lot of counties they'll have a warm line. Have folks heard of this before?
Mm-hmm.
Yes.
A couple folks have heard of it. So for those who haven't, this is it's like in King County, it's part of the Crisis Lifeline. But these are folks, volunteers who will talk to someone just to provide, again, support and just genuine care and concern, a nice person to talk to if you're feeling lonely. The benefit here that kind of puts it in this group of folks you can ask for help is that's connected then to a Crisis Lifeline. And so you're kind of getting both things, where it is pure care and concern with the option to get specific help for suicidality or a crisis. So professional contacts is usually where most approaches that are not safety planning start, where the assumption for managing a crisis is here's what you do in a grave emergency, right? It doesn't include that whole run up to this. The safety planning, again, the whole idea is that you organize a framework where it goes from noticing I'm in trouble, stuff I can do on my own, ways I can get some support and feel safe, people I can get specific help from. And if you've exhausted those things, then it's reaching out to your clinician. Ideally, right, if it was a perfect world, there would be all the systems and reimbursement and everything else to support on-call clinician support on some schedule. But that's often not the case, but to the extent it's possible, if there's an on-call person at your agency that can do this, that is a really good option. Local urgent care services, lots of different forms in terms of how this plays out. So for example, if you're in Pierce County, right, there are community mental health centers you can actually access, the crisis centers, which kind of offer a little bit more intermediate options. Here in King County, we don't have that same level of options, but certainly have some intermediate options via the crisis line and some of the mobile crisis teams that can assist with this. And then that suicide prevention lifeline is there at the end. What is noticeably absent from this list? Yeah, so 911 isn't on this list. It's not wrong to put 911 on the list of options here. The one potential benefit, if we're focused on suicidality as the purpose of the safety plan, orienting people to the lifeline as the last item on the list does have the benefit of Suicide Lifeline is equipped, trained, and really on board with helping do a rescue if it's needed. And they can make that connection to 911 in a way that might even be more helpful because they're going to be really committed to establishing rapport, initiating those interventions, giving immediate suicide-specific intervention and support while simultaneously initiating a rescue if it's needed. So that can be a nice pathway in terms of 911. 911 operators are incredibly caring and incredibly helpful, but they're not necessarily trained specifically in this, and they're not necessarily in that pipeline of suicide-specific intervention that the Crisis Lifeline is. But not wrong to put it on there, and for a lot of my folks I work with who don't have phones, they don't have a phone, we usually end that list with the place they're going to walk into physically because that's sort of their option. And for most of them, that's going to be the ED here at Harborview. So the last step here, it's the smallest section on the form, but it's like one of the bigger things you're going to do, is making the environment safe. So this is really the means safety piece of it. You may have heard this talked about as means restriction. There's a really funny little paper in one of the suicide journals where they looked at what people like to hear when they talk about making the environment safe. And people tend to be more willing to do something if you call it means safety than means restriction. So I just encourage everyone to call it means safety because it seems to help people feel a little bit better about the intervention. But basically, means safety is all about helping people think through removing their access or limiting their access to dangerous things. Means safety is an extremely powerful intervention because, as all of you have a sense of, and folks who work with people who are suicidal have a sense of, suicidality is this big black cloud. It's this big storm of thoughts and emotion and behavioral sequences that may have stretched on for years. And it takes some effort to unravel this and to work through it. And it might take effort and time in a way that really puts someone at risk if they are able to access dangerous things. Means safety is an extremely tangible intervention that can be sort of enacted right away that allows the time and space for this other process to play out. So means safety really should always be a part of this conversation because it gives you the opportunity to do the hard work of resolving longstanding drivers of suicidality. And so the sort of general principle for this is to always talk about firearms medications because they're so ubiquitous as kind of mechanisms of trying to hurt or kill yourself. So about half of suicide deaths are firearms, like 51% in the last year of data. And most firearm deaths are suicides. So just for some very practical physical reasons, firearms should always be a part of that conversation, including the ubiquity of firearms in a lot of American homes and communities. Medications, again, are ubiquitous as kind of mechanisms for attempted suicide. So a lot more people survive attempts to kill themselves or hurt themselves with medications. And again, it's not just the highly scheduled, highly controlled substances to think about here in the world of prescription medications. One of the things to be most concerned about, right, is Tylenol, the thing you can buy by the gallon at Costco, right? Extremely dangerous medication with really poor survival if it's not, if there's not an antidote early on. And so those are the two to always talk about just because of those kind of bigger environmental reasons. And then the third thing is, I say other specific means, this is anything that you know about from your really effective assessment that is going to be a problem for your patient. It's going to be a vulnerability for your patient. This can be a range of different things. So this can be different kinds of edged, sharp objects that are in that person's life that they need to think about, that they've either used before or are thinking of using. But this can also be really specific things like a CPAP machine, where someone is thinking of hurting themselves with their required medical equipment. This will come up as people talking about using their prescription and absolutely required insulin to kill themselves. Where you've got to really think through how you're going to manage things that people need in a lot of medical settings. So those are the three big categories. You can't insulate someone from all dangerous things. That's impossible because, right, people are going to walk near roads. People are going to probably need to prepare food in their home at some point. But you can do pretty much for any object that's dangerous, you can do at least something to reduce the ease of accessing it, to make it where folks have a moment to think and to maybe enact their safety plan. So for some patients I've worked with, this has been any drawer in their kitchen or cabinet that has a sharp thing inside of it. They reinstalled those child locks from back when their kids were little. That's not perfect, right? An adult can overcome a child safety lock, but it increases the time it takes, the effort it takes. And anytime you increase the response cost of a behavior, you decrease the probability of carrying out the behavior. And so this is something to be thoughtful about with your patients, is how can we be creative together? Given that some folks will have a hard time being able or willing to make the environment safe, getting in touch with people who share the household or are helping that person is really important. We're really a huge benefit in Washington State is that we actually have the legislative work that's been done so that in Washington State you can give firearms, for example, to any other person who's eligible to have them without doing a formal ownership transfer. You can temporarily give them to them or for the purpose of helping them be safe. And that's a good thing because people have always kind of done this, but now it's not illegal as it actually technically was for a long time. So that's a really big deal for firearms, but really anything. And so with medications, you could think about, if I've got a big amount of medication because it's dispensed to me in a large amount, can I have a trusted other person hold on to the big stockpile of medication and give me a few doses at a time? Or can they help me in some way? Also collaborating with pharmacists around this in terms of how much is going to be dispensed with pharmacists and prescribers. And also, if you have the option, using blister packs to help, again, increase the difficulty, increase the effort required to access medications. It's remarkable to talk to people who have had blister pack medication, who were thinking of killing themselves, and who gave up because it was such a hassle to get all those pills out. And so just thinking about it doesn't have to be an ultimate protection against dangerous objects. That's not possible. but even a modest increase in the hassle associated with doing something works pretty well. So just some resources here in the state of Washington that are really great. So Safer Homes is a whole big coalition of like everyone. So it's not just injury prevention and suicide prevention types, but they actually partner with the Second Amendment Foundation, the sports shooting associations. They've really worked hard to create means safety, particularly for firearms materials that are culturally appropriate, that are sort of pragmatic and effective around helping people to find safe solutions for firearms in particular, but also things like medications, where locking them up is a really effective intervention. There's also the Lock It Up program that has a website. They do all kinds of different giveaway events, as does Safer Homes for locking devices. They also implemented a coupon for a discount on safe storage devices for firearms and medications. And they were part of the legislative initiative that got rid of sales tax on these devices, just to make it a little bit less financially burdensome. If you have someone who wants to get rid of those old medications, wants to get rid of the obnoxious amount of narcotics they got from their dentist 7 years ago for whatever dental procedure, there's a website you can look at here. There are these medication disposal sites all over King County and everywhere else in the state. I just know all the King County ones from patients here, but other places, there's a whole list for the state of Washington. And then it's not just medications, right? People do things like consume drain cleaner, other caustic chemicals, pesticides, lots of things people will use to hurt themselves, where it might not be the best thing for the rest of us to advise them to just throw it in the trash or to dump it down the drain. And so if you're working through this planning in advance of a crisis, there's ways to connect people with other kinds of waste disposal. And then I just put our website from the Injury Center up as having a bunch of other resources. And we tend to collate and put out via Twitter and other sources the news about when the next giveaway events are going to be. Because a lot of different groups in Washington are giving away gun locking, medication locking devices, trying to make this as accessible as possible.
And that's statewide.
And that's statewide.
Yeah.
So Safer Homes is statewide. They do events all over the state. I just put up, they have these materials online that you can download and print off to give to folks. And these have been, again, designed not just to be really helpful, as they of course are, but to have a message that's going to be resonant across all kinds of different socio-demographic communities, in particular, because when we think about means safety, particularly the issue of firearms, this can raise a lot of cultural barriers to having that conversation. And this has been designed with stakeholders from all the different groups to help overcome that, where it could be acceptable and appropriate and feasible to talk about something like firearms, as well as medications and other dangerous objects. And you can also see it gives a nice, really brief message about we all do so many things all the time to keep our home safe, and locking up firearms and meds is just like that. It's the same kind of thing. So you could put a similar amount of effort into that as you do to having car seats for your children, that kind of thing. Other tools I've shared with the group before, but just to remind everyone that these are smartphone-based devices. So if you have folks who have access to a smartphone, these are developed by the federal government. So they are on iOS and Android platforms and are completely free. And you can see, especially with the My 3 on the left, it's really apparent that it's that safety planning format is in there, right? So it's designed in that way, where it goes right down that numbered list and even puts their picture there, so you can just tap their face to get help. And then the virtual hope box, again, it's a little bit different, because the hope box idea is that middle part's going to be pictures and videos that cause you to feel hope and cause you to feel connected with the things that matter in life. But the components in coping and the other parts of the hope box are similar to this. It's just a little more explicit in the My 3 in terms of safety planning. So with that, I'm happy to answer any questions. And I think we're just about on track for timing here.
Ah, beautiful. Thank you.